Hey everyone, Dr. Mike here. Today we're diving into a procedure that sounds intense but is a total game changer in medicine. Placing a central line. So, what exactly is it? Think of it as a special IV, but instead of going into a small vein in your hand or arm, this one is a long, thin, flexible tube, a catheter that goes into a large central vein in your neck, chest, groin. These big veins are like superhighways that lead directly to the heart. This direct access is what makes a central line so powerful and so useful in a hospital setting. It's a critical tool for some of our sickest patients. So, why would a patient need one of these? The reasons are actually pretty diverse. Sometimes a patient needs medications that are too harsh for smaller veins and could cause damage. A central line delivers these strong medicines like certain types of chemotherapy or powerful vasopressors that support blood pressure safely into a large volume blood vessel where they are diluted quickly. It's also essential for patients who need long-term IV access. Imagine needing antibiotics for weeks or receiving nutrition directly into your bloodstream, a process called TPN. A standard IV just wouldn't last that long, but a central line can stay in place for an extended period, providing reliable access. Another major use is for monitoring. In the intensive care unit, we often need to get very specific information about what's happening inside a patient's body. Alright, before you even think about approaching the patient, you need to have all your equipment ready to go. This isn't a procedure where you want to be running around looking for supplies midway through. It's all about preparation. Most hospitals have pre-packaged central line kits, which is incredibly helpful. These kits are your best friend. When you open one up, you'll find almost everything you need neatly organized. It typically contains the central line catheter itself, various sizes, different numbers of lumens or ports. You'll also find a needle, you'll also find a syringe, you'll also find the all-important guide wire. Let's break down the key players in that kit. The introducer needle is what you use to find the vein. Once you get a flash of dark, non-pulsatile blood, you know you're in. Then comes the guide wire. Thread it through the needle into the vein. The wire is your placeholder, it secures your path into the vessel. The kit will also have a small scalpel, usually an 11 blade, to make a tiny nick in the skin. This helps the next tool, the dilator, pass through the skin and tissue more easily. The dilator does exactly what its name suggests. It widens the tract to make room for the actual catheter. Beyond the main insertion tools, your kit includes items for safety and finishing the job. You'll find a sterile drape, which is a large sheet with a hole in it that you place over the patient to create a sterile field. There will be antiseptic solution, usually chlorhexidine, for cleaning the skin thoroughly. You'll also get a syringe and needle for injecting local anesthetic like lidocaine to numb the area and make the patient more comfortable. Finally, the kit contains suture material and a needle driver to secure the catheter to the skin once it's in place, along with a sterile dressing to cover the site and prevent infection. Before any needle touches the skin, we have to handle two incredibly important steps: patient consent and setting up a sterile field. You need to sit down with the patient, or their family, if the patient can't communicate. Explain what you're about to do in simple terms. I usually say something like, we need to place a special, larger IV called a central line. It's your job to explain the benefits, explain the risks, explain any alternative options. Risk, bleeding. Risk, infection. Risk, a collapsed lung, pneumothorax. Risk, blood clots. Risk, abnormal heart rhythms. You also have to mention the possibility the procedure might not be successful on the first try. After you've explained everything, give the patient the opportunity to ask questions. This conversation builds trust and respects the patient's autonomy. Once they understand and agree, they sign a consent form. In an emergency where the patient is unconscious and there's no family, we can proceed under implied consent to save their life. A specific exception. Now, for sterility. This is non-negotiable. Central line-associated bloodstream infections, or CLABSIs, are a serious and preventable complication, so we go all out. This starts with you. Perform thorough hand hygiene, put on a surgical cap, put on a face mask with shield, put on a sterile gown, put on sterile gloves. This is called full barrier precautions. Anyone else in the room, nurse or assistant, should also wear a cap and mask. We want to create a bubble of sterility around the patient. Next, you prepare the patient. If possible, have the patient wear a mask, or at least turn their head away from the insertion site. Clean the skin over the chosen site, the neck, chest, or groin. Use a chlorhexidine-based antiseptic with a vigorous back-and-forth scrubbing motion for at least 30 seconds. Then allow the area to air dry completely. Do not fan it, do not blow on it, just let it dry. Once the area is prepped, place the large sterile drape over the patient. Only the clean, prepped skin is exposed through the opening. Your sterile fortress is now complete. Okay, you're sterile. The patient is prepped, your gear is ready. It's go time. The first step is using the ultrasound to find your target vein. Let's say we're using the internal jugular vein in the neck. Place the sterile-covered ultrasound probe on the neck. Identify the vein. Large, dark, easily compressible. The carotid artery is rounder, thicker-walled, pulsatile. Once you have a clear view, you'll numb the area. Take your syringe with lidocaine. Inject a small amount into the skin to create a wheal. Advance the needle deeper along the planned insertion path. Inject more anesthetic as you go. Always aspirate before you inject. Now for the main part, accessing the vein. Using real-time ultrasound guidance, take your introducer needle attached to a syringe. Advance it through the numbed skin toward the vein. You want to see the needle tip on the ultrasound screen the entire time. As you enter the vein, you'll see the vessel wall tent, then pop as the needle goes in. At the same time, gently pull back on the syringe plunger. The moment you enter the vein, a flash of dark, non-pulsatile venous blood fills the syringe. Confirmation. Hold that needle perfectly still. With the needle securely in the vein, carefully disconnect the syringe while holding the needle hub. Immediately cover the hub with your thumb to stop air from entering the vein. Now grab your guide wire. Feed the flexible J-tip end of the wire through the needle hub into the vein. It should advance smoothly with no resistance. Advance it about 15 to 20 centimeters. While you do this, watch the cardiac monitor for any arrhythmias. If you see any, pull the wire back a few centimeters. Once the wire is in, safely remove the needle, leaving just the wire in place. You're on the home stretch. Take your scalpel and make a tiny nick in the skin right next to the wire. Thread the dilator over the wire. Use a firm twisting motion to advance it a few centimeters into the tissue. Remove the dilator, leaving the wire. Finally, thread the central line catheter itself over the wire. Advance the catheter to the desired depth. Once the catheter is in place, hold its hub and pull the guide wire out completely. Confirm each port has good blood return and flushes easily. Suture the catheter to the skin and apply a sterile dressing. You did it. Placing the line is a huge step, but the job isn't finished yet. The first thing you must do after securing the catheter is to confirm its final position. You need to be absolutely sure the tip is in the right place, typically the lower third of the SVC, right before it enters the right atrium. The gold standard is a chest X-ray. Get the X-ray read before infusing. An improperly placed line, for example up into the neck instead of toward the heart, can cause serious complications. While you wait for X-ray, do a bedside check. Aspirate blood from each port. Expect easy dark return from every lumen. If you can't get blood back or if it's bright red and pulsatile, major red flag for arterial placement. Use EKG as another technique. Some guide wires catheters connect to an EKG monitor and you'll see the P-wave change as the tip approaches the heart. Maximal P-wave equal sign SVC atrial junction. This guides placement in real time. Common mistakes to avoid. Losing the wire. Never let go. It can disappear into the bloodstream. Keep a hand on the wire until fully removed. Accidental arterial puncture is another error. Ultrasound helps distinguish vein versus artery. If you hit an artery, remove the needle and apply firm pressure for at least 5 minutes. Aftercare equal sign infection prevention. Keep the site clean and dry. Use a transparent semi-permeable dressing after insertion. Monitor for signs of infection, redness, swelling, pus. Change dressing per protocol, usually every 7 days or sooner if soiled or loose. Scrub the hub with alcohol or chlorhexidine every access. Meticulous, consistent care keeps the line safe.